I'll introduce me. That's fine. Yeah, I'm James Platts-Mills. I'm at the University of Virginia, and I'm an adult infectious diseases doctor, but then actually kind of spend most of my time doing research, and the focus has been application of molecular diagnostics to enteric diseases broadly, and the kind of big first focus was revising estimates of etiology of diarrhea. And we're getting kind of more into enterics and long-term consequences and such. So I think that's kind of the broad scope of what I'm going to talk about. Yeah. All right, so I'll jump in. Yeah, so I think some of you kind of...
Warning while you're getting ready for all of us is that these guys probably aren't familiar with all the acronyms of ABCDs and GEMs.
Yeah.
So we should probably make sure we're...
Yeah, I'll do my best.
I worry about us more than you. Mike, you got to introduce yourself quickly.
Mike Burns, doctoral fellow at PATH, the Drug Development Program.
Hi, Mike. Thanks for coming. Yeah.
So James, I think you're gonna have to come up here.
Oh, really?
Well,
I have.
Do you have a thing?
Oh shit! I didn't bring it.
Perfect.
I have the microphone here.
And does this move things forward? We've got
Yeah, no, I'm like so set up. You guys have no idea. Okay. Yeah, I have. So I'm going to talk about the use of quantitative PCR for diarrhea etiology first, and that's kind of will be the main focus. So where we came to this from was a scenario in which you had really good diagnostics for some etiologies of diarrhea and very poor diagnostics for others. So you do a study and you want to know what's causing diarrhea, and you have one really good diagnostic and you have one really poor diagnostic, and you find a lot of the thing that you have a good diagnostic for. What do you really learn? So the goal was to kind of try to level the diagnostic playing field. You have enzyme immunoassays, you have some culture, even you had some microscopy. You have some gel-based PCR culture and then PCR typing to look for toxins that subset E. coli into diarrheagenic E. coli. And if you use PCR, not surprisingly, you increase the sensitivity across the board. So that was the goal, right, is to have a level playing field. The downside of that is that it's really, really sensitive. So the good part is that it's sensitive. The bad part is that it's really sensitive. You can see that it's not uniform across pathogens. So, I mean, this is a good example. The rotavirus enzyme immunoassay is a pretty good test. It detects a lot of rotavirus. Yes, you detect more by PCR, but you haven't determined that those additional detections are relevant, that if detected in diarrhea, they're etiologic or not. The adenovirus enzyme immunoassay you can see is really, really poor, and that's been defined. And actually, the first study I'm going to talk about and what this is from, the GEM study, which I'll explain in a moment, actually did an adenovirus and enzyme immunoassay to look for adenovirus. And if that was positive, then they did a second enzyme immunoassay to type the enteric group adenoviruses that are thought to be causes of diarrhea. So basically you have even poorer sensitivity by nesting your tests. You can see for bacteria that cholera is much more easy to culture than, say, Shigella and pretty much everything else. So you get this increased sensitivity, and then you got to figure out kind of how to get back to what's really causing diarrhea. And the reason that's the case is that if you go and do PCR testing in children who do not have diarrhea, in the sorts of settings where we're doing these studies, many of them will have 2, 3, 4 pathogens detected. So just doing cross-sectional studies of diarrhea, looking for pathogens and saying, oh yeah, these were causing diarrhea, just doesn't work at all. So when we were thinking about what our analytical approach was going to be for taking this really, really sensitive PCR diagnostic, but trying to then conservatively attribute and get back to what's etiologic, we stumbled across a paper written a while ago in the field of malaria. So I'm going to use that as a case study and then kind of come back and apply it to diarrhea. So let's say your goal is to determine what proportion of fever in children in a setting that's hyperendemic for malaria is caused by malaria. So maybe the first study you do is you have 100 children consecutively enrolled with fever, you do blood smears, 80% have parasitemia. So you conclude that 80% of the fever is caused by malaria. Good, you're done. And you're like, well, I don't know, I think sometimes, there's asymptomatic parasitemia, so we should probably check. So let's enroll 100 children with fever and then 100 age and sex match well children and do smears, and you get 80% of those with fever have parasitemia and 85% of those without fever have parasitemia. Then you conclude that none of the fever is caused by malaria. So which of these is right, and can you do anything to better this? And so one argument is that incorporating the degree of parasitemia can be very, very helpful. So this is an example of that. This is a study from Tanzania, hyperendemic setting for malaria. And if you look here at the percents of febrile and afebrile children who have no parasitemia, there's actually slightly more children with no parasitemia that had a fever than were afebrile. So this is close to what I was saying, like it's 90% and a little less. 89% and 92% in the two groups. And you can see that actually the odds ratio for parasitemia, actually the percent febrility and the odds ratio goes down until finally when there's a really high degree of parasitemia, it goes up. And this has been described that if you have fever from another cause, you get some lysis of red blood cells with the immune response, and you actually can suppress low-grade parasitemia. So they come in with fever, and they're less likely to have parasites than the day before when they had some asymptomatic parasitemia. So you take that, and the goal is to try to fit, some kind of regression across this to say what is the, which of these can really be considered malaria fevers versus non-malaria fevers. And this is the approach they took. And this has made its way into the malaria field in that the RTSS vaccine trials, their primary case definition of malaria is fever with a parasitemia cutoff. Hasn't worked maybe as well as they hoped it would in that setting, but that is what they do. So we took a similar approach for looking at etiology of diarrhea using a really, really sensitive test. So I'll try to walk you through this slide, and then I'll kind of jump through a few conclusions that you get when you take this approach. So GEMS, I mentioned before, this is the very large 7-site case control study, Gates funded in Africa and Asia. They enrolled almost 10,000 cases and controls, and we randomly selected across the age strata and across the sites about 300 cases and match controls per age group and per site so that we could kind of maintain that structure. Using quantitative PCR for all of these different causes of diarrhea. So if you pick just one of these, this is a complicated figure, but let's just look at rotavirus. So the x-axis is the quantification cycle. So when you do quantitative PCR, as you go to the right, this is a higher quantity of rotavirus detected, and this is very little, and this is the analytical limit of detection. Essentially, this is a reproducible detection, is about 35 cycles, and after that it would be stochastic whether you detected it or not. The dark bars are the number of detections on the secondary y-axis in cases, and the lighter bar is the number of detections in controls. So at this very lowest quantity of rotavirus detected, there was really no difference in detection in cases and controls. As you go to the right, you can see essentially you don't detect this quantity of rotavirus in controls. And so then we used a conditional logistic regression to fit this data, and you can get a quantity-specific odds ratio for it being a case versus a control. And then we use that as an inference to when, in a case, rotavirus is detected at a specific quantity, whether you can consider that to be etiologic or not. So it is fundamentally conservative. We start with the prevalence of rotavirus in all the cases, and then we go case over case and say, well, rotavirus was detected in this one, but was it detected at a quantity we think is really differentiating, from cases and controls, and therefore we can infer attribution. You can see for some pathogens, this association is a lot weaker. So Campylobacter, certainly a cause of diarrhea in a challenge study. No one's questioning whether Campylobacter causes diarrhea, but there's so much exposure to it, and there's buildup of natural immunity that the controls have a lot of Campylobacter detected. So you get some over a population, you get some differentiation, but it's very conservative. The estimates we have are conservative for Campylobacter because we're applying a relatively, stringent requirement by using this approach. So this is how you get the odds ratio. So from there you want to attribute, and the way this is done is using an attributable fraction. So the idea behind the attributable fraction and the formula for the attributable fraction is effectively 1 minus 1 over the odds ratio. So if the odds ratio is 1, that quantity of pathogen does not predict at all whether it's a case or a control, then you can't attribute detection of that pathogen at that quantity as a cause of diarrhea. And as the odds ratio goes up, you asymptotically approach 1. You can then go case over case, pathogen by pathogen, and say, okay, in the first case, we detect Shigella, this was the quantity, this is odds ratio, this is attribution, and then you sum them up. And then you can use Bootstrap and get confidence intervals around that. So this is the approach we have used. And we've now used that in this GEM study and a second cohort study, and then we've used it actually from these same models to extrapolate to other studies where we don't even have controls, basically to try to do this conservative attribution for etiology of diarrhea. Yeah.
Basic FD question that I don't really answer. So does the baseline prevalence in a given population of the different pathogens affect your attributable fraction in that, or it's a stable number for everyone?
Well, I mean, these are in these studies, the baseline prevalence matters in that the higher the prevalence, generally the more subclinical carriage you expect to see, and the estimates are age and site specific. So when we say Shigella is detected at this quantity in this case, it's also in this age group and at this site.
Okay.
Yeah.
Yeah.
And that matters more for some pathogens than others. Yeah. So this is attributable incidence of etiology-specific diarrhea in children, in infants, and in the second year of life, in GEMS, and blue is our reanalysis, and salmon is the original microbiology. What I think is really nice here is that if you look at Cryptosporidium, the estimate really didn't change at all in either year. Rotavirus, it went up a little bit, but not very much. Whereas for other pathogens, say adenovirus, I mentioned that the assay they used was really insensitive. It went up a lot. This is satisfying to me because it means, yes, we're detecting twice as much, again, rotavirus, but it's not epidemiologically significant. It's all low-level detection that is not associated with diarrhea. So this kind of two-tiered, pick a really, really sensitive but quantitative test, and then conservatively attribute based on detection with that test. I think that's some evidence that it works. What's really striking here is certainly adenovirus, that adenovirus would be poised to be the leading cause of moderate to severe diarrhea in children in Africa and Asia after introducing rotavirus vaccine. That's really was not on anybody's radar at all. And then Shigella is really striking in the second year of life, as many kind of 7 episodes per 100 child years, and this is in, severe disease.
And why do you have that inverse with the Etiologica?
Yeah, so I don't think so. It shouldn't be able to go down. What I know about those is that cysts are hard to break up to get DNA out. And this was all also testing that was done on archive specimens that have probably had some freeze thaw. So I think that where the nucleic acid is relatively difficult to get, we actually may have lower sensitivity with PCR than they did with the ELISA for Entamoeba histolytica. We do use bead beating. That is my best answer. Yeah, definitely relatively uncommon for PCR for the attribution to actually go down. Those are also, kind of at the margins, the prevalence is pretty low. So, how stable it is, how clear of a difference that is. But it is lower, yeah. And it makes some sense that it would be that pathogen versus others to me, in that it's just hard to recover nucleic acid from. Yeah, Aeromonas is a different case, actually. So the PCR is specific to Aeromonas hydrophila, and the culture picks up other Aeromonas species. So I think that's the explanation for that. Yeah. Mike?
This is sort of more of a microbiology question, but is the reason that you sort of have Shigella and invasive E. coli sharing lines that, aside from culturing differently, they're similar genetically?
Yeah, they're incredibly similar.
Yeah.
And to the people who do the genomics, their question would be, why do you guys care? What's the big deal? It's just a name. They're essentially the same pathogen. But it does matter from the standpoint of, say, Shigella vaccine development, where enteroinvasive E. coli doesn't share, these same potential vaccine targets. So I think it is a meaningful distinction. We've done a fair amount of metagenomics from these GEMS stools in which Shigella was detected, and we think it's the vast majority of Shigella rather than enteroinvasive E. coli, like 90% upwards. So we actually, in subsequent papers, have dropped that /EIEC and kind of put an asterisk and said, see this study, it's mainly Shigella. But I think that's the fairest way of presenting it, is that, yes, some of that could be enteroinvasive E. coli. Yeah. It's the IPA-H gene is conserved across them, so that's the only target that we're using here. I definitely think there's a future for all of this stuff where it's diagnostic metagenomics. Like why would you use probes if you don't have to? If you can just amplify and sequence everything, or potentially even don't even amplify and just run it through a pore and sequence as it goes and then bioinformatically identify pathogens, that's probably ideal.
Just the quantitative.
Yeah, people kind of agree to disagree about how quantitative you can get. In theory, if there's no amplification step, then it's a little bit more quantitative than if there is an amplification step. That's my understanding. And we're trying to do this with Campylobacter to do sequencing because we don't otherwise have a way of detecting a lot of non-Jejuni coli Campylobacter. So we're going to attempt to give at least semi-quantitative data out of that, but we'll see. So we've kind of concluded with this analysis that we seem to have, mostly closed the diagnostic gap. So in this original GEM study of moderate to severe diarrhea in children in settings where there's a lot of infections, you would assume you're kind of expecting that the vast majority of that diarrhea is infectious diarrhea. But they were only able to attribute just a little under half to a particular etiology. So there was a question when they initially published that, like what represents that other 50%? Is that a diagnostic problem, or are there other etiologies of diarrhea we don't recognize? They started doing some sequencing, and all of a sudden someone was thinking that Serratia was actually the leading cause of bacillary dysentery based on the sequencing they did, but that story kind of blew up. Yeah, went up in smoke. So yeah, we don't think so. MAL-ED, unlike GEMS, was not a etiologic study of diarrhea. It wasn't cases of diarrhea and then matched controls. It was birth cohorts, so about 2,000 kids across 8 sites followed from birth with active surveillance. The nice thing there is you get the full denominator of diarrheal disease rather than just who comes into care. And you also, obviously the nice thing with a cohort study is you can look at diarrhea, but you can look at other outcomes as well. That's the beauty of having a cohort study. And this is a really, really well described cohort now. It's had a lot of testing for a lot of different things, so it's kind of continued to be an interesting place to have this qPCR data. So here, the increase in Shigella is even more striking. So it went from about 5 episodes of Shigella diarrhea of any severity per 100 child years up to around 25. So that's not a whereas GEMS was maybe a 2-fold increase if you put these 2 years together, this is more like a 5-fold increase. And as I mentioned to Judd this morning, we work in Tanzania, and one of the MAL-ED sites is in Tanzania. We didn't culture Shigella successfully in that site. So Shigella is hard to culture, and it's particularly hard to culture if you're doing a field study where you have to go to the home and collect a stool, maybe that's been sitting in the diaper or has already been collected. The stool needs to be put in transport media to maintain viability of Shigella. And Shigella culture is finicky, and it's probably very dependent on who's doing the testing. I remember one of my kind of first favorite stories from doing the PCR in GEMS is that we found a really striking differential sensitivity of salmonella culture versus PCR by site. And across the 3 sites in Africa, one recovered 70% of PCR detected salmonella, and the other 2 was less than 10%. And I just had no idea, like, how could that possibly be? I then went to a meeting where they were planning VITA, which was a new study, post-vaccine introduction, like GEMS, replicating almost the exact same protocol. And all of a sudden, there was a discussion between the microbiologists about salmonella culture, and the microbiology head from Kenya said, are we going to keep using selenite enrichment media for salmonella? And the other 2 labs said, we didn't use that. This is this point that it's like, it is really hard to standardize what people do in the microbiology lab. There's a lot of kind of institutional knowledge and particular practices. So in a field study, really, really hard to detect Shigella. So while we didn't isolate Shigella in Tanzania, it was second to rotavirus in infants for etiology of diarrhea.
Sorry, Campy wasn't cultured. That was.
So Campy, yes, Campy is a unique case because we didn't do culture, we did enzyme immunoassay, and as far as we know, it's the only study outside of, only research study that's used an enzyme immunoassay for Campy. And that's a whole nother talk because we've subsequently realized that that assay picks up a lot of Campylobacter other than Jejuni coli, and that's really opened up a window for us to have insight on that. We think, up to half of all Campylobacter infections in these settings are non-Jejuni coli Campylobacter, I think. So Yeah.
The difference in the Shigella attributable, the difference in the attributable incidence between Malady and GEMS, is that a function of the proportion of non-diarrheal stools, or is that a true just difference in the way it's run?
Do you mean that it was like 7 in
Yeah.
GEMS and now it's because this is all, I think it's because it's all cause diarrhea of any severity. Yeah.
Oh, right.
So
Yeah.
it's higher quantities of
Correct.
gems.
Correct. Just the incidence of diarrhea of diarrhea of any severity is much higher.
It's also moderate severe.
Correct. They also had a heroic effort to get back to incidence estimates, right? Because they're doing a case control study. They have passive surveillance at a healthcare setting. They then go and do healthcare utilization surveys where they try to figure out how likely are children to present to care if they have diarrhea. And if clearly that's dependent on severity and et cetera, and do they have dysentery, do they not have dysentery? So they created all of these correction factors and then use that to get from there. And they also had limited enrollment to a certain number of children per 2 weeks, but so then they had to correct for their denominator of the number of children presented during those 2 weeks, then correct for healthcare utilization and get back to attributable incidence. So that's kind of a tough job. Cohort studies are a lot easier, for sure. That'll be an issue in the surveillance network. So this is just the first and second year in Malady. Shigella goes up a ton in the second year, and this is kind of become really relevant in terms of introduction of a Shigella vaccine. The EPI vaccine schedule is really crowded. Another diarrhea vaccine that had to be introduced very early in life would definitely be a tough sell already, based on what's there. And never mind that, the rotavirus vaccine and the pneumococcal vaccine, all of these countries that have Gavi support are going to lose Gavi support for it, and so it's going to be up to the governments to continue to fund this vaccine. So let alone how crowded the schedule is, it's also just hard to introduce new vaccine after new vaccine in resource-limited settings. But in terms of the timing, there's a real hope that the Shigella vaccine could be given later, like at 6 and 9 months or 9 and 12 months or something like that, around the time that measles is given, and still be mostly protective against Shigella. But it's an open question.
So this may have come up yesterday, but the overall mortality rate for diarrheal disease is probably 4-fold or something higher in the under ones.
Yeah.
So even though there's less Shigella, if there's a 4-fold higher mortality, then it's equal.
Yeah. So I think that is that is a really, really important question, a really important output, is try to define whether their sense that timing there being the people who might implement a Shigella vaccine, that it could be given later, is right. And I don't know that it's clearly right at all, based on the child risk factors. I think it's potentially answerable. The question is always, what is the hard outcome that you care about? Because in most of these studies, mortality is relatively low. And if it's medically attended, then the risk of mortality is going to go down. And is it hospitalization? But yeah, I mean, the risk is higher. There is. Yeah. And then obviously I kind of skipped over, so adenovirus really striking, and sapovirus, which hadn't been tested before. Sapovirus, like norovirus, is a calicivirus, is probably like a lesser agent of winter vomiting disease in the United States. We didn't have any expectation that sapovirus would be as high as this in community diarrhea. And in GEMS, it's there. To remind you, it's here, and it's here. So it's not nothing, but it is really high in Malad, either because of the sites included, because of the years of enrollment. Norovirus, every 4 or 5 years, there's another kind of global G2.4 strain that spreads and escapes, acquired immunity, and we don't know if that's the case for sapovirus, or, is it just timing? Yeah, and I think less severe, so that's at least part of it. But, I don't know. It's hard to know. I think there are a few things going on there. So yeah, maybe longitudinal surveillance will be helpful. Still, maybe these single studies don't really totally answer the question. I know. It's such a good idea. All right, so this is just by site to say, across these malady sites, there's a huge difference in terms of how much diarrhea is seen, diarrhea incidence, and then etiology-specific diarrhea. These estimates in Bangladesh are just absurd. Like 80 episodes of adenovirus diarrhea per 100 child years. Is that really possible? And we think we're using a relatively conservative metric for that. So in a study with active surveillance, home-based surveillance, asking lots of questions, mainly maternal report, but we have a lot of clinical characteristics, and we wanted to look at this a little bit. We've got, this PCR attribution. So the way this data was generated is this is actually a regression where the outcome is a continuous variable 0 to 1 AFE for every episode. So you subset to 6,600 some episodes of diarrhea. And for every episode, for each pathogen, you have a number from 0 to 1 that represents how much of that episode could be attributed to that cause. So these estimates, and then those were scaled for each pathogen, so they're somewhat comparable between pathogens. But basically, as you increase attribution to a pathogen, if you have the presence of these characteristics, how much does that predict that you had increased attribution to the specific pathogen? So some things here make a ton of sense. So blood and stool, we think of Shigella and Campylobacter as the agents of bacillary dysentery, so they're very strongly associated with blood and stool. Most of the viruses are, blood and stool suggests that that's not going to be the attributable cause, and Cryptosporidium as well. So that's pretty much what you'd expect. Bacillary dysentery causing colitis, very inflammatory, associated with fever, so Campylobacter and Shigella being associated with fever as well. And, it's all maternal report. It's not clear how great the exposure, the characterization of this exposure is. So I think all of this is hard to get really good, clear numbers on. Shigella being a longer duration, Shigella is associated with dehydration, as is rota and adeno, and this, in addition to there being a lot of adeno, it does seem to be kind of a little bit more towards the rotavirus end of things in terms of being a bit more severe. The noro and sapo, the agents of winter vomiting disease, being more associated with vomiting like rotavirus than the other viral agents. So a lot of this is, I think, consistent with the described epidemiology. Another thing that's kind of nice is if you create a metric for no etiology, so you do 1 minus the sum of attribution to all the other pathogens, such that if you're still 1 versus 0, then you weren't attributable to anything. So that's a no etiology episode. Having blood and stool, you're less likely to have no etiology. If you have a fever, less likely. Prolonged duration, no association at all. So the duration of diarrhea does not predict at all whether it's infectious diarrhea at all in this study. Dehydration, much less likely, et cetera, and much less likely to be severe.
How is severe?
So yes, that's Vesicari Light. So that's a score that was developed for rotavirus, so it includes a lot of vomiting characteristics, for sure. Yeah, and so yeah, when you look at severity here, you have to keep in mind that this is a severity score, and every time someone asks, well, what was the kind of subset that were severe? It's please define severe, because this is, this remains a problem, and in terms of which pathogens are going to show up. Yeah.
One thing that strikes me here, which I hadn't thought of before, is Shigella looks pretty severe in terms of symptomatology across the board, but then you have this prolonged duration, which means that either mothers are sitting at home with a really sick kid for some reason for a really long time before they bring him in, or there's sort of a crescendo in symptoms and they're bringing them in with fever later in the course of the
Yeah. Well, a few things to say about that. First is that bring in a community diarrhea study means basically, basically means go to a dispensary and pick up some antibiotic, any antibiotic, whichever one is best advertised or most widely available. So in Pakistan, 60% of episodes were treated with Flagyl, metronidazole. Totally irrational. Is going to do nothing except probably cause diarrhea. Sulfa is used a lot, which really shouldn't be effective against any of these. Maybe a little against typhoid, maybe a little bit, but yeah, the resistance is really, really high. Azithromycin and fluoroquinolones, would be kind of more agents you would think of using, or even parenteral like ceftriaxone, later generation cephalosporins if it were severe, and those don't get a lot of use for the most part. So I think we're seeing probably something more like the natural history of Shigella than we are seeing treated Shigella. And in the sites that use more macrolides, there's more resistance.
It's not necessarily the first time they showed up for care.
So this is the whole episode, right? So And that's one reason why, if we were talking about deriving a severity score or a Shigella differentiating score, keep in mind that at the point of care, you're not going to have all of this information. If they present after 2 days, well, in Shigella trials, Shigella challenge studies, which are done now on prisoners that are called students as opposed to prisoners that were prisoners. It's just the new prisoner. Students are the new prisoners. You have watery diarrhea first, and you have watery diarrhea for 2 or 3 days, and then you develop dysentery. So if you present early because it's relatively severe diarrhea and you get an antibiotic, then you may avert dysentery. So when I show you our efforts to look at a Shigella score in this study, that's a really, really important caveat. Yeah.
That's why for interventions, like, it's important not that we don't just focus on dysentery, because if we can catch them before they develop
Right.
dysentery,
Yeah.
that's really our goal.
Yeah. That's.
We gotta think about that a little bit.
Yeah. Yeah. No, that's right. If it's a vaccine clinical trial, then if the vaccine helps avert dysentery, then that would suggest it decrease the severity, I guess.
Yeah.
But dysentery is kind of a funky thing because Shigella is kind of like it progresses to more of a colitis.
Right.
And same with Campylobacter. It can be a small intestinal, dehydrating diarrhea, and then it develops colitis. So I don't know. That pathophysiology is kind of complicated. Like, what is the vaccine? How does the vaccine intervene on that? I don't know. So one of the outputs, and this has been some of the work has been produced from your group, really looking at this question of how good dysentery is as a marker of Shigella. And I think the data is all very, very compelling at this point. But in MAL-ED, about 4 out of every 5 episodes of Shigella attributable diarrhea are non-bloody. And Shigella is the agent of dysentery along with Campylobacter and then everything else lower. But still, there's a lot more watery Shigella than there is bloody Shigella. And this is important because we've had these long-standing guidelines for treatment of diarrhea that suggest that you should not use antibiotics except only for children with bloody diarrhea. And bloody diarrhea is just used as a surrogate for Shigella, effectively. So you should treat all bloody diarrhea. And for watery diarrhea, it might respond, but it's not worth it, and most of it's probably not going to respond, so you should just use oral rehydration and zinc in the right settings.
Do you have the data to be able to look at all the kids who presented with 1 day of diarrhea, 2 days of diarrhea, 3 days of diarrhea, et cetera, on which day that sample was obtained that they had Shigella, to try to get a sense of, at what point do the Shigellas become dysenteric? You know what I mean?
Well, so what we could, so in GEMS, we've looked at this a little bit.
Yeah.
So if you take all Shigella attributable diarrhea and you compare those with dysentery to those with not, those with dysentery have a maternal report of a longer prior duration before they presented. And it's not like, completely differentiating, but it's a clearly longer, statistically significantly longer duration of diarrhea.
But it could go into a score if you added on which day are you assessing.
Mm-hmm.
Then
yeah, that's an interesting.
Yeah,
it's an interesting question.
Yeah.
Whether the score would have to kind of reflect that. Yeah. In MAL-ED, I think we can just again take the envelope of all Shigella diarrhea and then look at maternal report because they're asked day over day. Did your child have 3 or more loose stools? Did you observe blood in the stool? So we can see what day they reported that, and we haven't done that. That's a great idea.
If you're coming in with less than 5 days of symptoms, you would never include dysentery in the score because nobody has it at that point. Whereas if you're coming in with more than a week, maybe it's actually pretty common.
Yeah.
Dysentery is such an easy to measure thing, but dysentery is such a score,
Well, not if the score, having a negative in your score is important.
So this obsession with scores may not be like totally apparent to everyone, but the reason is because there's kind of going to be very clearly a large push funded primarily by your neighbors, Uncle Bill and Auntie Melinda, to develop and deploy a Shigella vaccine. And the experience from the prior Enteric vaccine, and well specifically the rotavirus vaccine, is that if you just look at in a clinical trial protection by a rotavirus vaccine against rotavirus diarrhea of any severity, the efficacy is relatively low, and that deploying a score to look at reduction in severe rotavirus gastroenteritis has been very, very helpful to kind of really clearly define the benefit of vaccine introduction. So this has been we've been talking about this what would a Shigella score look like, and how would you really derive it, and how would you validate it? So just so all, the audience knows, that's where Jed's coming from. Yeah, I mean, and the more complicated you make it, the kind of less, I don't know, useful it is. Okay, so we just wanted to, look at this in MALID. This is one take on this, and I think that some of the caveats have already come up, and I can mention some others. So we said, well, we've got all these clinical characteristics that I mentioned. Why don't we just try to create model-based prediction of etiology? So now we don't have a scale from 0 to 1 of how likely it is attributable. We need a cutoff, because we need to be able to call every episode either Shigella or not, or et cetera. So we used an attribution of 0.5 or greater, like majority attribution of that episode to that pathogen, as what we think is probably a relatively stringent cutoff for an etiologic episode. So presence of blood is what the WHO guideline has. And so if you use that, your score would be pretty simple. You get a point if you have blood and nothing else. And then if your score is 1 or greater, which is 1, then you would be considered to have Shigella. But we derived a Shigella score that uses all of the clinical characteristics and age, and this is what it looks like. So you get 6 points if you have blood report by mom, point for fever, 2 points for prolonged diarrhea, no points for dehydration, -2 for vomiting because you're less likely to have vomiting with Shigella, a point for a high frequency, and then you can see this, big increase in the number of points you get as you get older, and I'll show you what the impact of this is. So actually, if you look at this first, so these are the just box plots of the distribution of the scores you get using this Shigella score by age group. So effectively, no episodes in the first 6 months meet that Shigella score cutoff. And this is a score designed to be at least 80% specific. So we picked the first point on the ROC curve that had greater than 80% specificity. And that's a score of 17 or greater. And the AUC for the ROC curve is 0.78, which is actually pretty good. And you identify 20% of episodes that have a score of 17 or greater, and that gets you about 50%. So 50% of the Shigella attributable diarrhea. So you can develop a score that gets you half of the Shigella and identifies 20% of episodes to do that. What you can see is clearly age is a massive part of that score, but it's not all. So even in these oldest children, where the Shigella really ramps up in the second year of life, if you have 17 points because you have this, but then you have vomiting, you're not going to be treated. So effectively, you can kind of go through and say, children greater than 19 months will be treated for Shigella unless they have vomiting. So all watery diarrhea in the absence of vomiting would be treated. In this group, you could either have 15 points for age. So let's see, to get to 17, you could either have prolonged diarrhea, certainly all with blood, or if you had fever and high frequency alone, and then no vomiting. You can kind of go through and see what it would take for these clinical characteristics to add up to this score.
But you almost have to have blood to get your score, right?
Not in the oldest children. So if you're at 12 points, which is you're between 10 and 12 months of age, you could have 12 plus 1 plus 2 plus 1 would get you to 16, which wouldn't cut it. So infants, only with dysentery. In the second year of life, graded based on those other clinical characteristics. It's not perfect, and one caveat is we have all the information, not just the information available at the point of care, which isn't realistic. Another caveat is this is assuming that all Shigella episodes are created equal in terms of the value of identifying them and treating them, and this is missing any Shigella that happens to happen in infants. Even though that's rare, it could be very, very important because it's really dangerous. So, that said, right now, the reality is that if a child is 4 months old and they don't have dysentery, then the recommendation is to not give them antibiotics. So we're only incrementally improving on the current guideline. The current guideline is you identify 5% of episodes, which are those in which maternal mom reports blood, and that detects 14% of the Shigella episodes, and it's pretty specific, but it clearly isn't as good as identifying 50% of the episodes of Shigella with a score that identifies 20%. So effectively, we looked using the antibiotic use in MALID, and you go from kind of 1 appropriate episode of antibiotics per 13 to with the score something like 1 per 4. So you can kind of rationally you decrease antibiotic use versus what's observed right now because no one follows the WHO guidelines. The WHO guidelines would further restrict antibiotic use, but would obviously miss a ton of Shigella. So hard to know ultimately where you go with this, and it still doesn't feel good enough. One thing is that we have markers of fecal markers of inflammation in MALI-D, and probably the most helpful one is myeloperoxidase, which is a marker of neutrophil activation. And you can see Shigella and then Campylobacter, the other cause of inflammatory invasive bacterial diarrhea, are those in which you see the most neutrophil activation. So one of the things we've discussed is if you go back to this score and then you add in a presence of inflammation or a titer of inflammation, would that be one way to incrementally improve on that without having to have a PCR field diagnostic? So at the point of care, a clinician would have kind of a, age this, this, and this, do a dipstick, and then based on the dipstick, you make a decision to treat or not. And I think you have to decide how much you care about sensitivity versus specificity, right? So here, of course, you could lower the cutoff. You'd have to accept some additional overtreatment. And, scores are, the AUC is what's, at least it's differentiating, but then you have to decide what your trade-off in terms of antibiotic exposure and treatment of your diseases.
It is double counting a bit, but what if you said that you not only had to have a high Shigella score, you also had, if you took kids who had a high Shigella score and the lowest quintile of viral score, so you're double counting the viral score.
Yeah, great. So we looked at that, and I think the AUC went from like 0.783 to 0.785. Like we were trying to see if we could basically, say like you'd have to additionally, like if you had a high specificity detection of a virus, then that would also knock you back down. No, it doesn't really seem to help. And it kind of makes sense that it could because we have all this other diagnostic data and you could kind of use it. We also tried changing the definition of Shigella, so like make it more specific, or Shigella AFE over 0.5 and no other pathogen over 0.5, or Shigella has the highest AFE and it's 0.5 or highest regardless of what, just different things, and it doesn't, all of that didn't change it very much.
Performance of this score change if you disaggregate children based on nutrition status?
And that's, MALI-D kind of has some ability to do that. I haven't tried it. You would use like a marker of chronic malnutrition, like stunting, something like that. I wonder how age is going to play into that. Yeah, that would be pretty easy to try. Yeah. 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 Yeah, it's pretty easy to try. And I've done like site over site, and it holds up pretty well at all the sites that have, like there are a couple sites where there's effectively no Shigella and you can't do the score at those sites. But at the other sites, the AUC is like over 0.7 for all of them, over 0.8 for like 3, I think.
And I think interesting
but yeah, I could try. Yeah.
As well.
Yeah.
I think the time of assessment might be really helpful because essentially, if you don't have dysentery and you've had symptoms for over a week, that might be very predictive of not having Shigella. Whereas not having dysentery alone doesn't. You know what I mean?
No, I think it's a good point, and this is something we talked about yesterday. Like, consider a kid with dysentery, like, and developing these models. That's a bad kid. Remove dysentery. Among those,
Yeah.
they're going to be severe. So now let's develop a model among those that are presenting with watery diarrhea.
Yeah, and I'm on that. Yeah, no,
yeah. So,
yeah.
If you increase the sensitivity, and you obviously will decrease the specificity. Have you looked, and from a clinical perspective, that will mean you end up using an antibiotic more and not treating Shigella. But are you treating CAMPy or ETEC? Like, have you thought about thinking a little bit about that? Would you end up?
Yeah, so that's interesting to me. Is if you had like a so when we were putting this into a manuscript and going for a relatively general medical journal to publish it, we were really nervous about even including this and saying, like, and we're very, very clear, this is assuming that it is correct that all of this Shigella should be treated. And there's a burden of evidence that is, not there now that non-dysenteric Shigella benefits as much as Shigella, and there's some observational data that suggests so, and maybe there's this trial that some people are doing that might help. That's basically how we left it. It would be another step to kind of say, well, additionally, Campylobacter should be treated, and ETEC should be treated, and all bacterial diarrhea should be treated. And then it would be effectively a bacterial score. What I can tell you is that, as we said, if you go back to the clinical characteristics, ETEC is just so bland. It's just diarrhea, and some of it has vomiting, some doesn't, some has fever, some doesn't. Other than absence of blood, it's not associated with anything, except maybe a higher frequency. So my guess is that by including the other things, that the ability of clinical characteristics to pick that out is actually going to get worse. But I don't know that for sure. Right, inflammation. I was just going to touch on a couple other things. That's kind of the main, I think, a couple other things. So one is rotavirus vaccine was really introduced here first, and then 2013 to 2015 in Africa, and then just now has started to be introduced in Asia, and there's been a lot of interest in monitoring the impact of rotavirus vaccine introduction. And a reasonably interesting question is, once the vaccine has been deployed, what is going to be the leading cause of diarrhea? Maybe it's still going to be rotavirus, and the next best vaccine is a better rotavirus vaccine, because we know in clinical trials that the efficacy of the rotavirus vaccine in Africa and Asia has been more like 50 to 60%, even against the subset of severe rotavirus gastroenteritis versus 90% in Europe and the United States. So also, this is where the mortality is. So you really want to know how the vaccine performs in those settings and try to optimize it as much as you can. So this is a recently completed project that we did in where our Malidi field site is in Tanzania, but in the hospital there. So we had talked about doing some kind of vaccine impact assessment, and I was visiting, and I realized they have paper ledgers month over month going back to 2010 with the same format for all admissions to the pediatric ward. It's about 15,000 admissions total. So I sat down for like a couple of days and did the first couple thousand, and then wrote a protocol and trained somebody, and she did the rest, and it was amazing. And it was just one row in a database for each admission, the date of admission, the age of the child, the discharge diagnosis, whether they died or not. And we don't have diagnostics in this, but we have diarrhea. And so you can see this is number of diarrhea admissions year over year, and this is June. And we knew that that's when the rotavirus peak was, and actually you can see here that we did some ELISA testing in these 2 years in a vaccine effectiveness study, and confirming those peaks are certainly rotavirus. So here's when the vaccine's introduced. You can see the peaks coming down, then we did a vaccine effectiveness study from, I guess, for about a year and a half, and then we did an etiology study for the single calendar year of 2015. So our thought was, let's show the broad impact of the vaccine, including an estimate of vaccine effectiveness and an estimate of reduction in diarrhea admissions, and then in the context of those data say, okay, now using qPCR, what are the causes of diarrhea presenting to this hospital? So this is a referral hospital in northern Tanzania. We estimated using, this is like a interrupted time series analysis. And we included an exogenous trend, though there isn't really any prior trend here. But that includes the kind of exogenous trend for the baseline outside of the peaks, which may or may not be fair. We were trying to be conservative. You get about a 44%, 45% reduction in diarrhea admissions in 2015. And the vaccine effectiveness was really high. It's actually one of the highest vaccine effectiveness point estimates that's been published, though obviously getting power to have precise vaccine effectiveness estimates is really hard, and in part because vaccine coverage tends to be really good pretty quickly. And where you want to do a vaccine effectiveness study is really here, where the vaccine's being introduced and it's just ramping up, and there's as close to 50% coverage as you can find. But here the vaccine coverage is around 80%, which is good. It's not great. So in that context, with pretty high vaccine coverage, pretty high vaccine effectiveness, and this clear reduction in diarrhea admissions, we still find rotavirus to be the leading cause. And that was a little confusing at first, until you realize that in most studies pre-vaccine introduction in Africa have suggested 50%, roughly 50% of all hospitalized diarrhea due to rotavirus. So this still represents a pretty substantial decrease, but it's still the leading cause. We also have done this in the Global Rotavirus Surveillance Network, which is a CDC, WHO administered project that was started when the impetus to first develop a rotavirus vaccine started to arise, and they wanted to really have an evidence base for showing the benefit of a rotavirus vaccine worldwide. Rotavirus is just like the very, very clear leading cause of hospitalized diarrhea. So GEMS is moderate to severe, but only 20% is hospitalized. So this is kind of another way of identifying more severe diarrhea based on hospitalization. And rotavirus really likely to be hospitalized because of acute dehydration. So it is a very high proportion of this particular subset of severe diarrhea. So yeah, pretty evenly around 40%, and that includes the Africa region is this top bar, and then here is region for the Americas, where by this time the vaccine had been fully deployed. So you get a sense of rotavirus reduction, and norovirus is really close. We had sites in the Afro region where vaccine had started to be introduced in 2013 to 2014. We don't have individual level vaccine data, but we just define people as either being age eligible or ineligible to get the vaccine based on when the vaccine was introduced in each country. And you get pre-age eligibility estimate of just over 50% is due to rotavirus, and then in age eligible children it goes down to about 20%. So actually pretty consistent with what we described in Tanzania. And a different list of pathogens after that. So this was preliminary work, and one limitation to this is that it is enriched for rotavirus in that they don't include dysentery and they don't include diarrhea that lasts for more than 7 days. So we have kind of been part of rebranding the Global Rotavirus Surveillance Network as a pediatric diarrhea surveillance network, and this is with still CDC and the WHO, and the WHO really kind of keeping these surveillance sites together. So all of the blocked out sites are sites that are in the rotavirus network, and then the hashed ones are ones we've included so far. And it says 30, I think we're aiming to get up to like 35 or 40 countries across 6 WHO regions. And there are sentinel surveillance sites that collect diarrhea samples from hospitalized diarrhea and a lot of clinical information, and then regional reference labs for each WHO region that have the PCR technology that we use and doing testing. And this is all no control, so we're relying on kind of inference from GEMS and MALI-D about how you should attribute etiology based on quantitative PCR. Those are my 6-month-old identical twin girls who are a great source for control specimens for various studies, and they don't seem to mind. They seem totally fine with it. Yeah, maybe. Yeah, we'll try to keep them out of the lab. So I'll end with 2 minutes on work on not looking at diarrhea etiology, but looking at long-term consequences of diarrhea, because I know this is an area that's of interest, and we've done a little bit on this, and we've used the same insight from quantitative PCR to try to look at this. So PROVIDE is a study that's a cohort study, and we had roughly 600 children, and it's just infants, and we want to look at growth, and we've had some evidence from MALI-D that all-cause diarrhea isn't associated with growth outcomes, which was previously described, and that may be because shifts in etiology or availability of treatment, unclear. But this is another study in which there's no relationship really at all between all-cause diarrhea and length. And so we came into this expecting that there would be if you knew what the etiology was. So now that we have this level diagnostic playing field and a way of kind of precisely attributing etiology, let's take that to go back to this study in which they saw no relationship between diarrhea and growth, do qPCR testing, and try to define that better. And this just recently is now in press. And so bacteria and protozoal diarrhea were associated, whereas viral diarrhea is not. And I think that makes all the sense in the world based on what we've seen. And when you start to look by etiology, this is just a hard analysis to power, even with 600 kids. And there's a real limitation to MALI-D, as the number of children per site is a big problem for doing these growth analyses. But you see cryptodiarrhea and maybe Shigella and Campylobacter, and those have been the list. Viral etiology is less so. ETEC may be a little less so as a bacterial diarrhea, but that crypto and Shigella and Campylobacter diarrhea should be more associated with growth deficits, and that's what we see. If you look at, we had markers of systemic inflammation, C-reactive protein in this study. You see crypto not associated really, but Shigella and Campylobacter, there's a bit of a signal there that children who have more Shigella and Campylobacter diarrhea, and we tried to time restrict it around the CRP measurements, so you lose even more power, but you kind of maintain the association. So that's probably right, Shigella and Campylobacter are associated with local and systemic inflammation, and at least partially why you see associated growth deficits, whereas crypto, maybe there's another mechanism. And CRP independently, associated with growth in that study.
Did you actually look at that specifically, like whether if you had Shigella and high CRP was associated with growth?
So, well, one thing we thought about doing is doing kind of like a mediation analysis. Is that what you call it? Yeah. I'm not such a fan of them, and I can't really ever figure out how to interpret them, but the idea is if you have like a causal pathway between pathogens and growth, and then you introduce a covariate that is thought to be directly along that causal pathway, that you should see a decrement in the relationship, and then you can kind of say how much of that relationship is explained. Yeah. There's so many other causes of systemic inflammation. It's not specific to diarrhea.
As just a predictor, if you put it in quintiles, for example,
Yeah.
you just said if you have Shigella or crypto or whatever, and
Right.
evidence of severe systemic inflammation, does that predict
Yeah.
growth?
Yeah, no, I mean, maybe that's a clearer way of looking at it.
I'm not showing.
Yeah.
It's not really a mediation.
No, not if you did it that way, yeah. So kind of episode over episode, And it may be better to do, now this was just a height attainment model. Effectively, we just said your outcome is your growth at 12 months, and then we give like summative metrics of your exposure to etiology-specific diarrhea over the whole first year of life. So it might be better to have like a more, longitudinal model to look at that. But it's I like the idea. I mean, it's another way of getting at that question of severity and what defines a severe episode of Shigella, what makes an episode of Shigella worth avoiding with a vaccine or et cetera. Yeah.
Do you have the myeloperoxidase and CRP from the same cohort?
We don't. No, we have myeloperoxidase and MALI-D, and the only marker of systemic inflammation we have in MALI-D was AGP. It was added to adjust ferritin to identify anemia as since ferritin's an acute phase reactant, then you can have like an AGP adjusted ferritin to make it a more helpful marker of iron deficiency. But I think we could probably use that. We don't have CRP, and we don't have myeloperoxidase in this study.
The problem is most people with
Yeah.
inflammation probably don't have systemic inflammation.
So that's
But
why
probably everyone who has gut inflammation does have systemic. I mean.
Yeah.
So biologically, why would you think a pathogen would affect CRP, which would then affect growth? If it's not going through
Because
gut
if you have
inflammation?
translocation in the gut because of gut inflammation, then that would be.
Yeah, that's one of the big theories is you get leaky gut and bacterial kind of inflammasomic.
So that would
some
suggest
proportion.
CRP and gut inflammation are associated.
I think they are. The problem is that
Yeah.
the vast majority of people with gut inflammation probably don't have that happening. A small proportion will.
Right.
So it'd be hard to see it unless you had a very, very large sample size.
Yeah.
Would be my guess. I don't know.
The other thing is that all the markers of systemic inflammation are not, we don't collect those at the time of episodes of diarrhea. Those are just, at certain time points. That's why the way I set this up, you see during the current interval in the past 4 weeks. So this is a repeated measures model where you have for each individual like a CRP at 12 and 24 and 40 and 52 weeks or something like that. So, yeah, right, exactly. No, I mean, it's really hard, and doing it in infants is so hard. Yeah, so here, the idea is, CRP, I mean, if you have a bacterial infection, CRP goes up, and it comes back down. So if you have Shigella diarrhea, and then 12 weeks later you have a CRP measurement, you probably shouldn't expect any relationship between those. That's why we limited to the past 4 weeks to try to see if that, kind of made it more specific, and at least it kind of retains the association, whereas it doesn't for anything else, so. I mean, I think that's a kind of a real signal, even if it's a relatively small one. But I am, pretty much done. So just in MALI-D, we've effectively done the same thing, but the difference is here we're looking at just subclinical enteropathogen carriage, and the real story is that you see some of the same pathogens. Enteric E. coli is another inflammatory diarrhea or another inflammatory bacterial pathogens that's not very strongly associated with diarrhea. The biggest difference is crypto, and we don't really have a good total understanding for why crypto's been different. This is just a conclusion side, thinking about ways you can use quantitative PCR in other studies and kind of mentioning, the context of ABCD, and are there kind of things we can do to better understand who should be treated, and, deriving scores, point of care tests, et cetera, et cetera. The WACh studies is a really interesting area right now. There are these big WACh studies that had no impact, and we just showed yesterday, and Andy Pendergast showed yesterday, that in SHINE, one of these big WACh studies, no impact on enteropathogen carriage at all. No impact on growth, but also no impact on enteropathogen carriage, like no. Yeah. WACh benefits, there's testing going on in that study as well, but we haven't seen results. But yeah, it is really hard to take children out of their environment, basically. Yeah. Yeah. That's it. Yeah.
Thank you
That's
so
it.
much.
Yeah.
My only comment, well, this is fantastic, but we did not spend 20 minutes on this. But I think this issue of timing of when we're ascertaining either biological sampling or just questions about duration or fever presence, I think that's something we need to really think about, because I think that because we're often looking at the cumulative reports at a later date, I think it may be very difficult at the time of presentation to use this sample.
Yeah, and that's why, actually, our conclusion in the paper we've submitted that uses that Shigella score is we don't say it should be validated in a study like ABCD. We say it should be derived in a study, because this is information that you wouldn't have. Yeah.
Cool.
So
Thank you so
I agree.
much. Sorry to
Yeah.
run out.
No worries.
You'll make sure that.
Yeah. Yeah, we have time. If there are other questions, I know.
So
If people have to go, it's totally okay. Thanks for coming. Appreciate it.
But yeah, we can keep talking. So that WASH stuff, that's in child schools, or did you also get environmental samples looking at pathogens?
I'm not aware that they've done environmental sampling in those studies. No, yeah, I think it's just stools. Yeah, the one thing that I was talking to Andy and Jean, who did SHINE, one of the things that's really intriguing about these results is maybe enteropathogen carriage is a good surrogate for whether you think a WASH intervention is working or not. And if that's true, then this notion of doing adaptive clinical trials, if you had candidate interventions, if it's like WASH is done because nothing works, then it doesn't really matter. But if you had alternative strategies, candidate strategies, this is somewhere where I think doing adaptive trials makes a ton of sense. To do an adaptive trial, the notion is like you kind of have an intervention, but then you have relatively quick feedback to change or modify that intervention. Here, it makes sense because you have, I would say, if you'd done SHINE and you got stools at 1 and 2 months and there was no reduction in enteropathogen carriage, you're kind of done. Yeah, you're kind of done. Yeah. Yeah. How else is WASH improving child growth if not reducing enteropathogen? If you have another plausible mechanism, I guess, sure. But that's really the thought. And so if it's not doing that at all, then you could potentially do really rapid, trials to look at other WASH strategy, which is appealing in a field where no one is going to have an appetite to wait 2 years. Like in SHINE and WASH benefits, forget 2 years. When you get those studies done and analyzed, huge studies and really long follow-up to again see that it doesn't do anything. So at least it presents a tool that could be used to kind of keep research going, I think, potentially in that area. But. Yeah. Yeah.
Here, the signs change depending on whether you're looking at 2 years or 5 years.
Yeah.
I'm really interested in this because when I had a poster at Image a year ago, I was looking at just using the Ideology culture data and culture /T start.
Yeah. Right, for EPAC.
And we saw if there was any detection of typical EPAC in the first 6 months, there was a significant drop in high-grade G-score at 2 years of age among children in the study. Super crude method.
Yeah, but that might be right because I think there's clearly this, EPAC is a really bad actor really early in life. And I think that's why I was so strongly associated with mortality at GEMS, is that it's not just that it's EPAC, it's that EPAC you get in infants. That's even true, I believe, in the U.S. You can see EPAC in neonatal intensive care units. So to me, it makes sense that kind of like children who do or do not have that really early insult maybe would have like different growth trajectories, whereas children who get EPAC later on, just qua EPAC, it doesn't matter that much. But it's if you get it really early, which many children do, or a reasonable number of children do. So that's interesting. I haven't.
You also have sort of a contradictory signal with later infection.
Mm-hmm.
So it went from being negatively associated with growth early,
Yeah.
and then you looked at it in the next period, and it was positive associated.
No, that's nice. I mean, I mean, there's so many things that are interesting about also like this notion that it's really the host as much as it is the pathogen. So, like if you do a study and you don't find Shigella associated with growth, if most of the Shigella infection is later and the children are healthier, then that could be part of the explanation. So that's really interesting. I don't think we've looked at that. When we did the height attainment model, for example, you could kind of summarize exposure to pathogens over the first 2 years of life and see how they grew it to in 5 years. But you could also summarize exposure by like 6-month increments and see. So maybe that would be nice to do and see whether that holds up. Yeah.
Something we heard at a lecture yesterday about EED was Peter Sullivan really felt like Giardia is really important for EED and growth. And for those of us in the diarrhea world, we're kind of like, yeah, Giardia is not important because we always see this negative association with diarrhea. What's your feeling about Giardia?
Yeah, well, I mean, I guess I think, I'm at UVA, where, Dick Grant is, down the hallway, and he's why MALID was funded. Gates said, we're going to do GEMS, and because we want to know causes of diarrhea. And he said, who cares about whether it's liquid coming out of the end of a long tube? Like, what does that have to do with anything? Just rehydrate them. That's not the real consequences. The question is, are they stunted, and is stunting's a surrogate for their poor cognitive development? Then that's what I really care about. Don't introduce a vaccine for rotavirus, just get them access to care. Introduce a vaccine for Giardia that may not cause acute dehydrating diarrhea, but sure as hell causes them to lose weight and not grow, et cetera, et cetera. So that's his perspective, and that's why he said, you need to fund a cohort study so we can look at these long-term outcomes.
Right.
So, I mean, I guess I think that's right. I don't think it's necessary that Giardia be, epidemiologically linkable to diarrhea episodes for it to be a clear enteropathogen. Yeah, and it's there. I don't know. The one thing to recognize about the 5 years is we didn't follow every child out to 5 years, so it's not even apples to apples in terms of, which children are included. I mean, there's some definite caveats to that. We just wanted to include it because the whole concept here is that these first 2 years are really critical. So if that's true, you shouldn't need to measure exposures past the first 2 years to look at the long-term sequelae.
But a similar thing
Yeah.
that we talked about with Shigella, if you treat it, then it doesn't cause linear growth.
Mm-hmm.
I wonder if analysis of Giardia, since flagella's used so much, if we're kind of masking the
Yeah.
linear growth.
Yeah, it's a really good question. Yeah. No, I don't think we have a way of teasing that out because to do that, we'd essentially be comparing sites because there's some sites where there's just so much metronidazole use. But we have, so actually, I don't think that's doing that justice. I think that's a really good idea. I mean, with the antibiotic exposure, it feels hard because there's confounding by indication. Like you were given antibiotics because you had relatively severe diarrhea, so you might see that antibiotic-treated diarrhea is associated with worse outcomes because those episodes that weren't treated probably weren't that bad. They got better very quickly. But Giardia, it's not even really probably that you're treating Giardia diarrhea. It's just metronidazole exposure. You do see a reduction in Giardia detection after a child receives metronidazole. We have looked at that, but we have not looked at trying to stratify the growth analysis for Giardia by metronidazole exposure or no. You have to think about how to do that, but I think it's a really good idea. Yeah. The other thing is that there are other agents that are effective against Giardia, including some that are used for mass deworming.
Really?
have some Giardia activity. So there's kind of a few reasons why it might be like a little hard. It's not really untreated Giardia that we're looking at.
In this graph here, the 5-year time point, is that exposure restricted for the first 2 years, and then you just looked at weight?
Yeah,
Okay.
correct.
That's all.
So it's just the exact same model and just replace the 2-year height outcome with the 5-year height outcome. Correct. Yeah. So, yeah.
So, is there any
Yeah.
effort, I mean, I think I know the answer, but just the kind of discussion,
Yeah.
to adapt TAC to the point-of-care tests? What's your-
Well, you know, this is, I mean, I think that we are going to pursue trying to make this cheaper.
Yeah.
And one question is, if you had a point-of-care PCR-based diagnostic for diarrhea, which pathogens would you go for? You know? Yeah, thank you. So do you just want to know if Shigella is there, or do you want to know if Shigella can't be crypto? You know, what does that look like? So Eric is pursuing some of this. There's a company in India that's basically making like a generic gene expert, where you could have like cartridge-based, put the sample in, extract it, do PCR, potentially have resistance genes or something in there as well. And then there's a QIAGEN collaborator in Germany that makes something called LabDisc, which is cool. It's like looks like a CD, and you put the sample in, and it's all microfluidics like TAC, but it takes it through stages of extraction and amplification and et cetera. So it's also, you just directly put like, you know, your sample into a well, and then the disc does everything else. It's a really contained system, and it's much cheaper than TAC. We're thinking about trying to adapt that for using even in the surveillance network long term. It would make it easier to expand it or contract it to other sites, because TAC is expensive. And you don't need 50 pathogens for most of these studies. Separate question is there any scenario in which you have like a clinical PCR diagnostic that would get wide use? And I think, you know, probably the answer is no. I wonder about a dipstick for inflammation as something that maybe makes a little bit more sense. This is, I mean, this whole field of like, can you distinguish bacterial diarrhea from viral diarrhea? And this, what is it called? The longitude prize? It's one of those two. This is Nestle, and I think,
Oh, really?
yeah, it's something like $10 million prize that's been open for years. Still open, you can still win it. And the challenge is to produce a diagnostic that makes a meaningful contribution towards the problem of antimicrobial resistance. So most people have interpreted that to mean, can you come up with a diagnostic that helps differentiate bacterial infections from non? So things like CRP and procalcitonin and, you know, the many, many, many other biomarkers that have been proposed for that purpose. And it has to work at the point of care on multiple different types of specimens for multiple different syndromes. So it needs to be able to distinguish bacterial and viral respiratory infections as well as bacterial and viral diarrheal, you know. Yeah, but that general field of like, you know, can you do that? And then, you know, kind of a host immunodiagnostic problem being a part of that. I think it was just like incredibly challenging. And there was a seminar about this at one of the Gates Grand Challenges meetings, and there was a physician from India, a researcher there, who said, you guys, you know, you go ahead and make that diagnostic, but let me tell you how things really are. There are 500,000 general practitioners in India. The vast majority of those make money by prescribing because they own the pharmacy. You create a diagnostic that tells them they don't need to use antibiotics as much, they have no interest in that diagnostic. The problem is alignment of incentives. It's like, that's it. Your prize should be to fix the economic model of how physicians practice in a world in which if they order tests, which is true in the United States, like everywhere else, like you know, now there's some states where you're not allowed to own your echo, but a lot of states you still can, you know, so, you know, just like, I thought it was really compelling. He's like, look, it's alignment of incentives.